let's move on, for the sake of time, to the last part of this segment, which is looking at the role of dual checkpoint blockade, both in treatment-naive and refractory non-small cell lung cancer, treatment-naive non-small cell lung cancer and the treatment-refractory and small cell lung cancer. Naiyer, you've been a part of some of these efforts. Can you talk to us about combination approaches for non-small cell and small cell, starting with MYSTIC?
Yeah, so I think we have certainly proof of concept for immunotherapy combinations in melanoma, where ipilimumab and nivolumab have been improved. We started working with IPI and Nivo in lung cancer a number of years ago, and found it was much more toxic, the combination in our lung population, than in the melanoma database. And so in general, we've been using much lower doses of CTLA-4 in our clinical trials in lung cancer. Nevertheless, the IPI-Nivo combination seemed to be very promising, high rate of response rate, including complete response rate in a number of patients. And that combination has moved forward in phase 3 trials in Checkmate 227, which is likely going to read out over the next few months or so, comparing combination immunotherapy with chemo combinations and other standard of care. It's a complicated regimen. There's also the MYSTIC trial, which is combining durvalumab and tremelimumab in first-line therapy versus chemotherapy, and that actually completed enrollment, and certainly at the first co-primary endpoint of PFS, it did not hit in terms of PFS in the first set of analysis. So that trial is ongoing. But I think that immunotherapy combinations is definitely another strategy which could be effective in lung cancer.
Yeah. And Checkmate 012 is another study looking at IPI and Nivo up front. We seem to see responses that are there, that are durable, and that may be contingent on PD-L1 expression. Is this what the potential future holds, is using these combination approaches without chemo?
I think that, I think that in the next sort of year, we're going to be sort of doing a sort of dual analysis for lung cancer. We're going to be doing PD-L1 expression, and we're going to be doing tumor mutation burden, because lung cancer is many diseases. It's not as clean as melanoma, for example. And I think that the paradigm that I envision is going to be that if you're TMB high, you're PD-L1 high, you should get immunotherapy, right, whether it's single agent or doublet. If you're TMB high and you're PD-L1 negative, then you should get CTLA-4 PD-1 combinations or chemo PD-1 combinations. If you're TMB low and you're PD-L1 low, there probably isn't a big role for immunotherapy for you. So that's kind of how I interpret the landscape right now.
Okay. Let's talk small cell for a second. We had some data published in Lancet Oncology. It's been updated at World Lung, looking at combination CTLA-4 PD-1 in recurrent small cell. I believe this is listed on the NCCN as an option. I don't know if it's necessarily FDA approved. People's on the panel's use of these drugs in recurrent small cell, given how little we have in this setting?
Yeah, I think it's reasonable to. If you look at the study that looked at combination of ipi-nivo in second-line treatment of small cell lung cancer, the response rate was promising, about 25%. This is a group where we don't have really good effective options. Topotecan is approved in sensitive relapse, but the responses even to topotecan are not long-lived. They are transient responses. So that's where the combination of ipi-nivo seems promising. When they gave nivo alone, the response rate was less than 10%. So if you're going to give immunotherapy in that setting, it may be the combination approach. And a randomized phase 3 trial in that space is ongoing, and we should find out, this year or next year about those. The NCCN has included this regimen in their recommendations as an option in the second line, primarily driven by the fact that there's nothing else to do for these patients.
Sadly.
So I think it's reasonable to consider. I have definitely given it to some patients in my practice. And I have seen some good responses in patients. So I feel optimistic, and I hope that this will fill in the much needed space in treatment regimens for small cell lung cancer.
Right, remember, small cell is a very smoking related disease. So very high mutation burden, so it makes sense that it would work here.
Right, and definitely I am offering the combination. I mean, you have to be cognizant of the potential toxicities if you stick to the publication, use the dosages that were in the publication. But I agree that I've seen some wonderful responses, but at the same time I've seen pretty severe side effects. So you do have to balance it. So it's for a patient that really has a good performance status, they can handle potential toxicity if it happens. But I'm definitely offering it, and I can tell you, I have colleagues at Fox Chase who absolutely don't like to use the combination because of the toxicity profile, and they're not convinced that the phase 2 is enough despite the NCCN label. So, I mean, everybody interprets this data a little bit differently, but I think it's a reasonable option.
Yeah, the immune-related adverse events are a little more pronounced with the combination approach. And I was encouraged by the World Lung update of this, looking at TMB, and I've started to send off TMB on these patients because that's really where you get a response rate up to 40% with combination approach with the TMB high. That is compelling and clinically meaningful.
Yeah, I mean, I think that, again, I think that TMB, provides some sort of, threshold that is required for immunotherapy to be effective. And, the interesting thing about, about small cell lung cancer is that they're almost all PD-L1 negative. 80% plus have no PD-L1 expression at all. So it's not a good biomarker for that disease. But if you look at TMB, and if you just look at the upper third of patients, those patients that got IPI and Nivo together had a 1-year survival of like 70%, which is like, just, crazy. But if you got single agent PD-1, they really didn't do very well. So I think that identifying the subset based on TMB is a reasonable thing to do, and give them combination IO.